Hello, everyone. Can you hear me okay? Yay. All right, welcome to tonight's very exciting event. Is it hot in here? Menopause Explored and Explained. My name is Julia Ray. I am the manager of adult programs here at New Canaan Library, and I want to thank our partners at Stamford Health for putting on this very topical presentation. And before I begin my intro, I want to give you all a second to silence your cell phones and also take note of the auditorium exit there. If you don't feel like walking through the library and want to get right out to your car, you can go right out there. I also want to make a note that we have index cards. If you think of a specific question that you want addressed, you can go ahead to that table and write your question and drop it in one of the baskets or hand it over to me. And I'll be sure to deliver your questions to the doctors for the last portion of the event. And also, we are recording today's event, so if you want to watch it again and again, you certainly can, and I think I'll be able to send out the slides as well. All right, so Dr. Dolan and Dr. Fucigna, leaders of the Department of Obstetrics and Gynecology at Stamford Hospital, will be speaking about menopause at length tonight. It's a topic that isn't addressed enough in the media, and so we're hoping to fill in some information and dispel some myths tonight. Using data and best practices from the North American Menopause Society, yes, there is a North American Menopause Society, Dr. Dolan and Dr. Fucigna will present all of the facts and facilitate a community conversation about this very important topic. Dr. Dolan is the chair of the Department of Obstetrics and Gynecology at Stamford Health. Board certified in obstetrics, gynecology, and clinical genetics, Dr. Dolan received her medical degree from Harvard Medical School, completed her residency in OBGYN at New York Hospital, Control Center, Medical Center, and Yale-New Hospital, and did her fellowship in clinical genetics at Albert Einstein College of Medicine in Montefiore Medical Center. Dr. Dolan is building an innovative program at Stamford Health by integrating genetics and genomics into all aspects of care to make it truly personalized. Dr. Fucigna is a physician with 30 years of experience in obstetrics and gynecology. Her practice encompasses all aspects of obstetrics and gynecological care, from adolescents to postmenopausal women, with a special interest in managing perimenopause and helping women with the menopausal transition. Dr. Fucigna is the vice chair of the Department of Obstetrics and Gynecology at Stamford Hospital and an associate clinical professor of obstetrics and gynecology at Columbia University. We're in very good hands tonight, so please join me in welcoming. I believe Dr. Dolan's coming out for, okay, they both are. Thank you. Thank you so much.
Good evening. Thanks so much for having us. I'm Siobhan Dolan, and I'm joined by my colleague, Carol Fucigna, and we're delighted to speak tonight about the topic of menopause. As I said as was just said, just to reiterate, we're going to talk about 30 minutes. Dr. Fucigna and myself have prepared some materials so we can kind of set the stage, but we really then want the second half of the program to be Q&A. So there's cards, there's a couple boxes back there, so please feel free to write down any questions that come to mind, and then we'll look forward to answering them in the second half. So tonight, like was just said, this is a topic that isn't always talked about, but honestly, the time has come, and we're happy to join the national and actually international conversation about menopause tonight with some facts to get started, and then we can talk about the complexity of this topic. So many of you might have seen this article. It was in February of this year in the New York Times Magazine. The writer was named Susan Dominus, and she wrote an article about her experience of trying to decide whether or not to take hormone replacement therapy. And the end of the story, and the story was titled, "Women Have Been Misled About Menopause." And actually through the whole spring and into the summer, there's been a lot of interest. She's done a podcast, the most recent one in July, Menopause is Having a Moment. And so this idea of being misled, I think, is an important point to think about. And so what I want to do with the next slide is just kick off what is menopause, but then talk a little bit about what these facts are behind this misleading idea. We're here tonight to kind of break down any sense of being misled. There's facts, there's figures, there's statistics, there's risks, and we each have to think about those in consultation with our own personal physicians to decide what to do for our own health. So there's not a simple answer, but there's lots of good data, and certainly our goal is to not have anyone with a sense of being misled. So menopause, just to give the facts, it's a normal natural life event. It's defined as the final menstrual period, and actually there's a whole period of perimenopause, which is confusing. One period comes, there can be a period of like a gap of time, so there's irregular menses. But when someone has had 12 consecutive months without a menstrual period, that is considered menopause. The average age in this country is about 51 to 52, so this can start anywhere from age 40 up to age 60. And again, there's a period of perimenopause, and then a year of no menses, and then it's considered menopause. So those are sort of the timeline facts that are important to have in mind. Issues that can influence the timing of natural menopause include genetics, which is sort of a proxy for family history. What was your mother's experience? What was your grandmother's, your aunt's experience? And also smoking. Smoking accelerates or causes a more an earlier menopause in most cases. And the things that are not correlated with the age of menopause include the age at your first period, the use of birth control pills, or using fertility medication. So just to kind of sort out what's been demonstrated to be associated and what's not, those are a couple of the items. So as I mentioned, the dynamics of perimenopause, part of why it's confusing is it's not like exact dates, but the concept is a pretty clear timeline. So when someone's born, a woman is born with all the eggs or oocytes that she's going to have, and in fact, the peak number of oocytes is in fetal life. A female fetus has the maximum number of oocytes or eggs, and then when born, there's about 1 million eggs in your ovary. And it's the cells around the eggs that actually make the estrogen. So from birth through the course of life, you actually are always losing oocytes, and you don't ever regain. This is not personal, it's just an observational thing. No one means to gain or lose oocytes, but it's just, this is sort of the statistical aspects. So what you see here on the bottom is a timeline, so age 30, 40, 50, and 60. And as I mentioned, at birth, the average woman has about, or the average female newborn has about 1 to 2 million oocytes. By age 30 years, your ovarian reserve, right, the number of eggs is now diminished, and it's at about 25,000. And then what happens is this a period of time where you continue to lose eggs or ovarian follicles. And then as that happens, your estrogen level goes down, that's in the blue line, and the FSH level, that's the green line, goes up. FSH is secreted by your brain and tells your ovary, make estrogen, make estrogen. So when your ovary can't make estrogen anymore, the FSH level goes up. So that's why you see the blue line and the green line in inverse relationships. Excuse me, the estradiol is the blue dotted line. Progesterone as well is the second female hormone, but those both decline as ovarian function declines. And as you can see, it could start as early as 40, 41, 42, but there's a period of perimenopause because it's a sloping line, and the exact slope of that line is different for different women. So for some women, it's very abrupt. For some women, it takes this sort of diminishing ovarian reserve takes place over a longer number of years. But at the point then when your estrogen level is very low and your ovarian reserve is depleted, about less than 1,000 follicles, that's when you have, in general, your last menstrual period, and that's considered menopause. Does that make sense to everybody? So it's kind of predictable that you're not really sure, is this perimenopause or not? But if it's between 40 and 60 and you're starting to have irregular menses, this is sort of, you're somewhere on this timeline. And actually, with any of these things, you need a couple points on the timeline to know where you are. Now, some of these hormone levels, they can be measured, but again, you don't usually have a point in time that tells you this is exactly where I am, but you can have different hormones measured over time to get a bit of a trend of where you are. So just to kind of outline that, then the stages of menopause, perimenopause being usually a 2 to 12 month period with, again, no periods, that's called amenorrhea, or more commonly irregular periods. You have one, 3 or 4 months without one, and then you might have a heavy period. What's that Sex and the City? And just like that, there was a whole episode in the last season when one of the women doesn't have a period for a long time and then goes to an outdoor event wearing white jeans and has this very heavy period, right? So it's just like, it is like a kind of a a thing that sometimes is experienced, and so then, it's kind of very relatable because you have this real sense of uncertainty. The perimenopausal transition can be about 3 to 5 years. And then the menopause, like I said, average age 51 to 52, and 95% of women actually reach menopause by 55 years. So that's, again, this is natural, this is common. And again, you don't have precise statistics, but you have a sense of the trend in this period of time. So what happens is then in this period, from age 0 to 45, you'd be, sort of premenopausal, right? So having regular menses, you might have some symptoms, you might not. Different women are different. Perimenopause, age 40 to 51, and then you start to get some of these symptoms, and that's what we're going to talk a lot about this evening. Hot flashes, weight gain, irregular periods, night sweats, and loss of libido. And then with the menopause from age 51 and on, then sort of much more significant symptoms, and then they can become aggravated or worsen with time. So this is sort of the outline of the stages, and again, we're going to get into some of these symptoms and what is appropriate treatment for symptom relief. Now, hormone therapy, as I said, has been sort of demonized, and I'm going to tell you about that in the next slide, but the truth of the matter is hormone therapy is the best treatment. It offers the most relief for the most common symptoms, which are vasomotor symptoms. So that is a blanket term for hot flashes and night sweats. So hot flashes is just a sudden flush of heat. It can be very disruptive, and if it happens at night, and then it can disrupt sleep. And as a result, a lot of women end up feeling fatigue, exhaustion, and so forth. The other set of symptoms are genitourinary symptoms, and that is basically the vagina is, estrogen is a stimulus. It's like a pro-stimulus hormone. It keeps the cells of the vagina like growing and reproducing rapidly. And so when you don't have estrogen, the vaginal mucosa thins, and it can be have more atrophy, and then it can be associated with discomfort, a variety of symptoms, which again, Dr. Fucigna is going to go into, but genitourinary symptoms can be very upsetting and difficult to tolerate. So again, hot flashes and vasomotor symptoms, and then genitourinary symptoms are two of the biggest buckets that most women experience. And then there's prevention of bone loss, which again is a bit more of a long-term situation. We want to have your bone density as high as it can be. Once you no longer have estrogen, then your bone density diminishes over time. So we'll talk a little bit about that, but that doesn't usually cause as many symptoms in one's 50s. That's an adverse event that can occur down the road. We are going to stick to the general treatment goal that we want to have symptom relief for women. That's absolutely the goal, but we want to start with the lower doses of estradiol and titrate up until we have symptom relief. And the goal is really shared decision making. So what that means is that is not an absolute answer. So one has to come to the table as a patient with a sense of, like, what are your values and your priorities? What are your concerns? What is your family history? How do you value like discomfort in sex versus long-term bone loss, right? Like, what is your personal experience of those things? Because it's not absolute. And when you're weighing all these different symptoms and all these different factors that impact your quality of life, then what you value and how you think about it is part of the decision making. Then we as physicians are going to work with you on that to sort of say, okay, I hear your values, here are the statistics, and then we come to a shared decision. So that is a simple phrase, but it's not at all a simple activity, but it's certainly what we're trying to provide as clinicians and invite all of you as patients and in any encounters to really participate in that notion of shared decision making with your doctors. Here's the story that was misleading, and it was actually fun for me to review all this the other night. I started practicing right around 2000, and actually I was in that first group where we thought estrogen replacement therapy was dynamite. And it was this period in the 90s and like early 2000 where there were observational studies that looked at women who took hormone replacement therapy, and they had very good cardiac outcomes. They had less cardiac disease. They were less likely to die from stroke, from coronary heart disease. And so there was this idea that, wow, well, women, when they lose their estrogen, are going to have high rates of heart disease like men who don't have estrogen and have high rates of heart disease. So why don't we try giving women estrogen, and then we'll see if it brings their heart disease rates down. Now, the thing about that to keep in mind is it's an observational study. So you're not changing who gets what. You're just saying, let me look out at the world and see what people are doing, and I'll measure who is taking estrogen, how is their hearts, how is their breast cancer risk, how is their stroke risk, and who's not taking estrogen, and I'll look at their hearts, their stroke risk, and their breast cancer risk. And so the common idea was estrogen brought down your risk of these adverse outcomes. So they designed a study called the Women's Health Initiative. It was about 16,000 women. It was a cohort study, which means you enroll everybody in the study and you randomize people. You say, everyone here is the same, and we're going to randomly decide who gets estrogen and who doesn't. And actually, we're going to say some people are going to get estrogen plus progesterone, some people are going to get estrogen alone, and some people are going to get a placebo pill. So they're going to take a pill, but it's not going to have any active ingredient. So they did that study, and they were watching for outcomes. And so in 2002, what happened was they saw a slight increased risk in breast cancer risk in the group of women who were getting the hormones, and so they stopped the study. Now that actually made enormous news, and it's actually the basis of that New York Times article, like what a dramatic stoppage it was. It was on the news, it was on, the Today Show and so forth, as if like it was an incredibly dramatic outcome. Well, it had reached a threshold from a statistical standpoint that breast cancer risk had. But the truth is that the increased risk was very, very small, and while the relative risk was a little increased in the women who took estrogen or estrogen plus progesterone, the absolute risk of breast cancer was still very low amongst the women. And then furthermore, there were other outcomes like bone fracture risk that were much reduced by estrogen. So it wasn't really quite such a black and white issue. But regardless, as a result of the media blitz, as a result of sort of the way it was spun out, the estrogen, hormone replacement world just plummeted, and people were like, you can't take estrogen, causes breast cancer. And it just wasn't that simple. So that's kind of the genesis of the misleading. I think over the past couple of years, people have sort of said, wait a minute, hormones have a lot of great benefits. You need to think and consider the various aspects of your health. But I love this quote in 2023, it's time to stop normalizing the suffering in menopause. And a lot of women are standing up and saying, you know what? These symptoms are so dramatic, so affecting my quality of life that I want to know what the facts are, and I'll make some decisions about which and how much and for how long I'll take hormones. But this idea that you can or can't take them and it's an absolute is really not the case at all. And I recommend looking at that, reading that Times article if you have a second. It's really very good. Here's another way of interpreting the data, which was that if you look, this is the Women's Health Initiative study, so this is what came out in 2002 and triggered the big media blitz about estrogen causes breast cancer, you can't take it. But when you really look at the breast cancer risk, if you look on the fourth column, there were 8 more cases among 10,000 women in the group of women who took estrogen plus progesterone. But in the group of women who took estrogen alone, there were 6 less cases than in the control group. And if you also look, hip fracture and colon cancer, those are negative numbers, so there was a lot less colon cancer and hip fracture amongst women in the estrogen plus progestin group. So again, on balance, there's risks and benefits to taking estrogen. And so the idea here is, with time, people have really looked at these studies and said, it's not an absolute, it's something to consider. The long-term analysis of the Women's Health Initiative did establish a few things. One is that they enrolled women in WHI who were already into their 60s and started them on estrogen, and the data supports that that is not a great idea. So if you're gonna start hormones, it's better to start them pretty quickly around the time of menopause, but if you've passed 10 years and you haven't started, then to add hormones at that point is not statistically advised. So that's something we learned from long-term follow-up from the WHI. And then there's a couple other studies that have confirmed that the long-term cardiovascular disease risk is not increased from hormones. The short-term estrogen progesterone use does not significantly increase the breast cancer risk and may be decreased with estrogen alone. So again, not the talking point that everybody hears about, but you really have to look at this in the long haul, and again, with particular risk factors. And then when to stop estrogen and estrogen plus progesterone, if you're on that, It's typically in the 60 to 65-year-old range, but again, not an absolute. You have to think about your own particular risks. So I think I'm going to turn over now to Dr. Fucigna, who's going to take us back to the variety of symptoms and then talk about some of the treatment options in the different categories of symptoms.
All right, so this is one of my favorite things to talk about, unfortunately, because I may talk for a long time. No, and I think that every bucket that we have for all of these symptoms, you can have a 2-hour lecture on each one of them. So I'll try to keep it as brief as possible. So premenopausally, again, age 0 to 45, we don't really need to treat any of the symptoms of menopause because they're not there yet. But then you have perimenopause, which can last from age 45 on average to 51 or 52. Some people it lasts from age 42 to 55 because there's a lot of variation in the ages of women who go through menopause. Some women will have irregular periods. Some women will just start having hot flashes and night sweats, and that will usually happen characteristically right before their period. So it's kind of like the day before, you kind of know you're getting your period because you can't sleep and you're sweating a lot. You may get some vaginal dryness, and people in perimenopause will also get more moodiness. And the reason for that is that in perimenopause, your hormones are doing this wide fluctuation. You're not on the steadier state that you probably were in your earlier reproductive years. Then when you get to menopause, which the average age is in the United States is 51, 52, some women sail through it and don't ever get a hot flash, and they just stop getting their periods, and they're very fortunate that way. Some women have horrible symptoms, hot flashes that really interfere with their quality of life. Some people get hair loss, cognitive changes. People will talk about having feel like they're in a fog, sometimes, especially during that first year of the transition. Weight gain is probably one of the biggest complaints that I get from women, because with menopause, we tend to get a redistribution of our fat, and it tends to go right into the middle where none of us want it. We also lose our lean body mass because we lose muscle. So some of the things that you can do to help that would be, aside from diet and exercise, it's really strength training and rebuilding your muscle, as well as cardiovascular to obviously burn the calories that we want to burn. There's also vaginal dryness, which is a big issue with women in menopause. There's lots of things that we can do to treat that I'll get into. Some women have joint pain, skin changes. Women will talk about really just their whole body changing. All these symptoms affect people differently. Again, the physical changes, redistribution of body fat, vasomotor symptoms or the hot flashes and the night sweats. The vaginal symptoms can be just kind of an underlying feeling of irritation. It can also be just having pain with sex. It can be just an overall feeling of vaginal dryness and not having that lubrication that you had before. Psychologically, some women will talk about depression. So a lot of women will also talk about anxiety. Some hormone replacement therapy will sometimes help with those symptoms, but some women may just need an SSRI or something to kind of get them through that transition phase. An SSRI is something that we give for a medication we would give for anxiety. Again, cognitive changes. Women will talk about just not being able to kind of clear their minds, feeling like they have a fog over them. And then the genitourinary symptoms of menopause are a lot around urine loss when you don't want to, right? You're out playing tennis, you're out running, and suddenly you have this violent urge that you need to pee and you can't because there's nowhere to go, and then you can't get to the bathroom on time, or you just start to leak some urine. And there's lots of things that we can do to treat that as well. So again, this is a sample of the vasomotor symptoms. Here you see women with fans in front of them because, it can be this sudden onset of this feeling of heat that comes over your body. And some people just feel it as just a mild increase in their temperature, but some people really feel the whole hot flush, and they get red and they start to sweat. And if you're in a meeting, that can be disruptive to your life. Hopefully not now that many of us are on Zoom meetings, but when you're in a meeting with your colleagues, it can be a little bit different. So the genital urine, let me preface it by saying most of these symptoms are from a loss of estrogen, because as Dr. Dolan was talking about before, with menopause, our estrogen level plummets. And when our estrogen level plummets over time, it affects probably every area of our body. And one of the areas that it affects most is our genitourinary system. So you will get some vaginal dryness. There's loss of elasticity in the vagina. There is shortening of the vault, which can also make sex uncomfortable, narrowing of the introitus, and then just an overall changing of the tissue in the vagina. Some women only have this as a symptom, and what you can do for this is these women probably don't need systemic hormone replacement therapy, but just vaginal estrogen cream, which I give to women probably 10 times a day, because many women just have this, or you can use vaginal estrogen along with systemic estrogen as well. But the good thing about vaginal estrogen is that women who have a contraindication to taking systemic estrogen, history of breast cancer, or a strong family history of breast cancer, so they're not comfortable doing it, the amount of estrogen that is absorbed vaginally is minimal, and you don't have the same risk of breast cancer, you don't have the same risk of blood clots in our bodies, because those are the two biggest risks of estrogen therapy. In 2022, the North American Menopause Society came out with a statement stating that for most healthy symptomatic women under the age of 60 who are within 10 years of menopause, the benefits of hormone therapy outweigh the risks, and that hormone therapy remains the most effective treatment for vasomotor symptoms and the genitourinary symptoms of menopause. So this is a big change from what came out in 2002 with the Women's Health Initiative study. And I was practicing in the city then, and there were many of my colleagues who just said, I will never refill my patients' hormones again, which is quite unfair to women, I would say. And many of us continue to do it. Again, with shared decision-making, we need to know benefit, risk, and the benefits of them outweigh the risks of them. So what are the considerations of starting hormone therapy when you're postmenopausal? Well, there are a couple of things. One, you can start hormone therapy when you're perimenopausal if your symptoms are significant enough. There's two options for perimenopausal women, really. You can start hormone replacement therapy. The downside to starting hormone replacement therapy when you have not gone through menopause yet and you're still getting periods is that it's a much lower dose of hormones, so your body can kind of bleed through it sometimes, and you may get some irregular bleeding. Hormone replacement therapy is also not a birth control. It doesn't act as birth control because of the low dose. So if you're taking that perimenopausally, you also need to be using birth control as well. The other option would be to take a combination birth control pill with estrogen and progesterone in it. And you can take birth control pills really up until the age of about 55 is probably the latest that we would give it. But what I usually do is at the age of 52, if you're on birth control pills, I would have you come off for a month, test your hormones kind of toward the end of that month, and we would see where you are. Because when you're on the pill, you can't test your hormones. So you can't tell if you're menopausal or not. If you're not menopausal, you can certainly go back on the pill and stay on it for a few more years and then test it again. If you are menopausal, you can kind of wait it out, see what happens to your symptoms. If you do have symptoms of menopause, you then have the option of going on hormone replacement therapy. So there's lots of different ways that we can do it. The FDA-approved indications for starting hormone therapy are the vasomotor symptoms, so hot flashes, night sweats, prevention of bone loss. We know that we start to lose bone really in our 20s and 30s. We kind of peak in our early 20s and it starts to go down. And then once we go through menopause and our estrogen level plummets, it's a much deeper trajectory of bone loss. And we know that estrogen is the most effective prevention of bone loss in women. Genitourinary symptoms, including sexual function. Other common indications that we use it for that are probably not on the FDA's bucket list would be sleep disturbances. Most of those sleep disturbances are awakening during the night, having night sweats, and what's happening is you're getting a hot flash, and that's what's waking you up at night. Mood disorders like anxiety and depression, and joint pain. I have a lot of women who, when they start to go through menopause, they complain of joint pain, and it is relieved when they go on hormone therapy. The contraindications to starting hormone therapy would be unexplained abnormal vaginal bleeding. And a lot of times, perimenopausally, that's a little bit hard to discern what the cause of that is. So the usual progress for that would be that if you come into the office and you have abnormal bleeding and symptoms of menopause, we want to rule out the cause of the abnormal bleeding first. So we want to do an ultrasound, take a look at the lining of your uterus, make sure everything looks normal, and then do a biopsy to make sure there's nothing precancerous or cancerous in your uterus that is causing that problem. And if there's not, and this is truly perimenopausal bleeding, then it's fine to start hormone therapy. Another absolute contraindication would be an active stroke. If you've had a TIA, a pulmonary embolus that's not provoked by having surgery of any kind, a heart attack, acute liver disease, a personal history of breast cancer, endometrial cancer, other estrogen-dependent cancers, those are all kind of absolute contraindications. There are some exceptions to that, in that there are some women who, although they have a history of breast cancer and or endometrial cancer, they will use vaginal estrogen to, again, quality of life issue. Women that want to continue to have sex throughout their lifetime, if you have vaginal dryness, even though you've had breast cancer, the benefit of using the estrogen outweighs the risk when you do it vaginally, because the risk is so low in your absorption. So relative contraindications are diabetes and hypertriglyceridemia or high cholesterol, because estrogens can increase your cholesterol levels. Active gallbladder disease would be a relative contraindication because we know that estrogens can affect that as well. Both hormone therapy and birth control pills will play a part in that. Hypoparathyroidism, some benign meningiomas, which are brain tumors. And then if you have a high risk of breast cancer, if a mom or a sister, again, that's a relative contraindication, and it's a shared decision-making. If your symptoms are so bad that you can't function during the day because you're up all night, that may be a risk that you want to take. And the risk of breast cancer, taking hormone therapy, if you were taking, in the studies that Dr. Dolan cited, if you were taking the hormones for somewhere between 4 and 7 years, the 4-year mark was if you were taking estrogen and progesterone, that's when your risk of breast cancer increased a bit. If you were taking estrogen alone, and people who take estrogen alone would be women who have had hysterectomies in the past, so they don't need the progesterone. The reason we give the progesterone to begin with is to protect your uterus from the unopposed estrogen. If you took estrogen over a long period of time and did not take progesterone, you have a high risk of getting uterine cancer. Taking the progesterone with the estrogen decreases that risk even below your normal baseline. So it's affording you protection. So women who took estrogen and progesterone in the study had a higher risk of breast cancer after 4 years. Women who took estrogen alone, it's thought to be more 7 to 10 years, because there's a difference in estrogen receptor positive and progesterone positive breast cancers. And then migraine with aura can be a relative contraindication. That's, to my knowledge, that's more with birth control pills, although the dosing of estrogen when you use hormone replacement therapy is much lower. So non-hormonal treatment options. If you decide that you don't want to take hormones at all, if you're, a strong family history, or you just don't want, some women just don't want to have hormones on their bodies, and that's fine, right? So some food and dietary modifications, decreasing sugar. Some women will respond well to decreasing wheat and decreasing dairy in their diets. It's very, very individual, but some women will play with their diets a little bit like that. Exercise will help with many of the symptoms of menopause. Behavior modifications. We know that there's some triggers for hot flashes. There are some foods that will trigger hot flashes, specifically spicy foods. A lot of women will talk about red wine triggering their hot flashes, so they'll stay away from that. And I think over time you learn what does trigger it, and then you learn not to use that anymore. There are some herbal supplements that will help. Most of them will have black cohosh in them. There's one, probably the name brand over the counter would be Estroven, but you can also get a black cohosh chaseberry supplement that will also sometimes help. The caveat to that is that The supplements tend to help if the symptoms that you have are fairly mild. They do not tend to help if the symptoms that you have are significant. There's just not enough in there to help you. Acupuncture helps some women, yoga and Tai Chi, meditation, cognitive behavioral therapy, and hypnosis. There's also, and it's not on this slide, but there's a new medication on the market that was just approved by the FDA on May 12th of this year, and the name of that medication is Veozah. That is a non-hormonal treatment for menopausal symptoms, and it acts on the center of the brain that protects us in our thermoregulation system. So it doesn't have any hormones in it. It happens to be that the thermoregulation and the estrogen receptors in the brain are very close to one another, and this happens to work very well. And I think it's going to be a great supplement for women who, have a history of breast cancer and have any history of DVT or blood clots, that they shouldn't take estrogen. I think this is going to be a great medication for them. And again, it was just approved by the FDA, so it's just available recently. There's another one on the that they're studying, which does not have one of those crazy names yet, but I'm sure it will. So the treatments and therapies for menopause. So again, a lot of the treatments are based on the person's tolerance of their symptoms. So some people have very mild symptoms. They may get help from taking some black cohosh. Some women will have very significant symptoms, and they really need the hormone replacement therapy to help them through that transition. There are some women who will use hormone therapy for 1 year and go off of it. Some women will go off of it at the 4-year mark. There are some women who will use it for the rest of their lives because they try to go off of it, and they, even at the age of 70 or 80, may have hot flashes. Those women usually need a very, very low dose of estrogen, though. Let's see, the norokinin 3 receptor, that's the new one that I told you about, that's Veozah. The off-label prescription therapies are the SSRIs like Zoloft or sertraline. They can sometimes help with hot flashes. Wellbutrin can sometimes help. Gabapentin in higher doses will sometimes help with symptoms of menopause, as will oxybutynin. And then non-prescription, we have, again, cognitive behavioral therapies. I can hardly read these because they're so small. Adaptation and cultural remedies, behavior modifications, those are the ones that we mentioned before. So I would say one of the most significant things that women come in with as well, aside from the hot flashes and the night sweats, that many women don't want to talk about or don't bring up. They're happy to bring up well, not happy to, but they're comfortable bringing up their hot flashes and their night sweats, but they're not comfortable bringing up urinary symptoms. So that's one thing that I think, if you're in your gynecologist's office, this is what we do all day. So it's nothing that anyone should be hesitant about bringing up, because there are lots of women who have some urinary incontinence, and many women it's very mild. One thing that really will help with that would be a vaginal estrogen, though. You don't need to take systemic estrogen for that, and you can certainly go the route of seeing a urogynecologist at some point and having that worked up. But many women do very, very well with just vaginal estrogen cream. You use 1 gram of it every night for 2 weeks, and then you use it twice a week on an ongoing basis. And most women will have very good results with that in both the control of mild urinary incontinence, as well as control of sexual dysfunction or dyspareunia, painful intercourse. If you do use it for painful intercourse, I usually tell people, in addition to that, to use a lubricant as well when you are having sex. So coconut oil works very well. Any of the over-the-counter KY products also work well. So there's a lot of things that you can use for that. Some women will use olive oil, whatever they kind of have around in the house, they'll try to use. And then for pelvic organ prolapse, so that is when you have a prolapse of the bladder or the vaginal wall, the uterus, down through the vagina. Some people feel that as a feeling of heaviness in their pelvis. Some women kind of can just feel the bulge coming out of the vagina, and that sometimes will get worse during the course of the day because of gravity. You go to bed at night, you're laying down, you wake up in the morning, it's not so bad, then over the course of the day, it can worsen because gravity pulls things down. The risk factors for that are age or being postmenopausal, because we know that tissue gets a little bit more fragile. Multiple vaginal births or parity, because we know that that can damage the tissue of the vagina a bit, and then add menopause to that when the tissue becomes more fragile and you have a difficulty supporting the organs. The treatment options for that are observation, because many women don't even know that they have it. I saw a woman today in my office and who had significant prolapse, but she had no symptoms of it whatsoever. So there's nothing that you need to do for it at all. The recurrence rate can be as high as 30% after you do have surgery, but you can also have surgery again if you choose to go that route. And if you do decide to do that, you would do that with a urogynecologist, because they really specialize in those surgical procedures, sling procedures. And then again, treatment for the genitourinary symptoms, hormonal intervention is the local estrogen, DHEA, which are you can put suppositories. DHEA is a precursor to estrogen and testosterone. So if you use it vaginally, it can actually help with the symptoms similar to what estrogen does, probably not as strongly or not as quickly. DHEA does not do the same if you take it by mouth, though. And then the other is oral medications. There's Fucigna is one of them. I have very few women who have taken them, honestly, but the ones who have taken it have been happy with it. And then non-hormonally, we have moisturizers, lubricants. You can use vaginal dilators. Many women who maybe hadn't had sex for a while, they were, and then started having it again after 10 years and find it painful, they would benefit from a vaginal dilator because you're slowly dilating the tissue again. And you can do all of these things in conjunction with one another. You can use vaginal dilators, you can use vaginal estrogen creams, you can use the suppositories as well, kind of at the same time, alternating them. Some women also have very good results using a vitamin E suppository. That will help with sexual discomfort. And then these are all the different estrogen and progesterone treatments available. I won't go through all of them, but in general, if you have a uterus, you need to use estrogen and progesterone. I tend to use a transdermal estrogen, meaning an estrogen patch that you change twice a week. The reason I like the patch is that it has a lot of increments that you can increase and decrease with. It also gives you a lower risk of blood clots rather than taking it orally. And women do great with it. You can use it swimming, sweating, working out, etc. You do need to take progesterone at the same time, but that you have to take by mouth. Progesterone is not well absorbed through the skin. So using a progesterone cream is not going to work, and it's not going to give you nearly enough protection of your uterus. So you need to take that by mouth. And the progesterone itself also, it just naturally makes us more tired. So I always tell my patients to take it in the evening, and then they tend to sleep better. And it's not a narcotic or a sleep aid, it's just something in our bodies that does that. So that's my go-to, is usually the transdermal estrogen with the progesterone tablets. If you don't have a uterus, you can just use the transdermal estrogen. There's also oral estrogen that you can take. There's many different brands. There's Estrace, there's Premarin. There's lots of different brands that has passed through the liver, so it does have a little bit more of an increase of blood clots in your body than using the transdermal type. And if someone's on multiple other medications, I like to spare their liver the effects of the estrogen, so I think that the transdermal works a little bit better for them. And then there are, again, vaginally, you can use a vaginal cream. You can use a vaginal tablet called Vagifem or Uvifem. And then there's a medication called Estring, which is for, just the vaginal atrophy, is a ring that goes into the vagina and stays there for 3 months at a time. Then you take it out and put a new one in. So that gives you a steadier delivery of estrogen, and then you don't have to remember to use something twice a week. So that works really well. Another thing that works well and some people will add to their regimen, is testosterone. One of the biggest issues also with menopause is decreased libido. The reason we have a libido is because during our reproductive years, our hormones are shifting, and when we're ovulating, we have an increased libido to facilitate getting pregnant and reproduction, right? after menopause, when our hormones plummet and they're now very, very flat, we often don't have a sex drive anymore. Some women will do well with just hormone replacement therapy, will increase their sex drive. Some women will add some testosterone cream to that. Testosterone cream is an off-label use for this. There's nothing really on the market for women that's an approved testosterone cream. But many of the compounding pharmacies will compound it for us. And you can just use a small amount of it every day, a couple of times a week, and you can play with it a little bit and see how it works for you. Again, all of these things are going to have risk and benefits, right? The risks of testosterone cream are going to be, if you're putting it on your arm, you may have a little hair growth on that arm because testosterone does that. If you use too much of it, you may have balding, you may have voice changes, but the amount that you would need to do that is not what you're going to get transdermally. So it's a pretty safe thing to use. So, and again, I think sexual health is one of those things that really is important through menopause. I think that it's, especially for women who want to maintain that as a part of their life, it's important for you to know that you can do that. One thing to remember is that if you are with a new partner, we often don't think about using condoms for birth control because we don't need it anymore, but there is a need for condoms if you're with a new partner to protect yourself from STDs, because we really are seeing more chlamydia, more gonorrhea, and even more syphilis out there right now. So it is important to kind of protect yourself. And it's something that we may not think of because we're not worrying about our getting pregnant. So vaginal estrogens, Intrarosa, Imvexy, these are all options for vaginal dryness. And then one thing I did want to mention is bioidentical hormones. Bioidentical hormones tend to be a buzzword for people, and I know a lot of women also have used pellets, which is probably my least favorite form of delivery of hormones because it's not regulated and we don't know what, most women do not know what dosage they're even getting in the pellets. Bioidentical hormones, they're not regulated by the FDA. So someone is compounding them for you, and there are a lot of great compounding pharmacies, but most of the hormones that we use are also bioidentical. Everyone thinks about Premarin, which is the one that's not bioidentical, that's pregnant mare's urine is where they initially got it from. But the Minivals and all the estradiols that we get now, they're really they're gotten more naturally, and they're the same, are very similar to the bioidentical hormones. So that's one thing that I would stay away from. And there's no, the North American Menopause Society, which is kind of not the governing body, but the body that we go to for all advice on our menopause treatment, really come out against bioidentical hormones. And they're very, very pro-hormone, but the regulation is important. And then lots of people will tell you that you should get your hormones tested and your saliva tested. And what I always tell my patients is that we're not treating your hormone level, we're treating your symptoms. When you do a hormone level, you're testing one moment in time, right? And our hormones are kind of all over the place. So I can check your hormones and they could look completely normal, but that doesn't mean you're not having the symptoms that you're having. And that those symptoms should be negated because you have normal hormones. We need to kind of look at the whole picture and not the numbers that we're looking at. And then just a word about well women care, because it is very important. And I know a lot of women got away from it with COVID because we weren't going to our doctors. But it's also a good time to talk to your physician about any symptoms that you might be having, menopausal, perimenopausal, urinary symptoms. And then you should have some screening, right? There are screens that are recommended for women over the age of 50. A blood pressure screen should be done at least once a year. A mammogram should still be done every year. Pap smear and HPV testing, they've come out and talked about doing it every 3 to 5 years, but that really depends on your history. If you have any history of having HPV or abnormal pap smears in the past, you should really have one every year. Colonoscopy, the recommendations around that have changed recently. The starting age right now is 45. If it's completely normal without a strong family history and no polyps, the recommendation is to do it 10 years later. If you have polyps or a strong family history, you're probably going to be called back 3 to 5 years later. And then diabetes screening should be done every 1 to 3 years. HIV testing should be done once, and that's probably done more in your kind of 20s and 30s for most women. And again, it depends on your sexual history. If you have new partners, it's something that you may want to do a little bit later as well. Bone density, we start at age 60 unless you're high risk, meaning that you have a family history of osteoporosis, you've had long-term prednisone or steroid therapy, any chronic disease processes. Some women with thyroid disease will have bone issues, so we want to test it sooner if that's the case. And then if it's normal, you do it probably every 3 to 5 years. If it's abnormal, we would talk to you about making sure you're getting calcium in your diet, making sure you're getting vitamin D3, and weight-bearing exercise, and you would then repeat it about 2 years later and see where it's trending. If you're trending downward, then I would send you to an endocrinologist to talk about all the options of treatment.
Great. Well, thank you for having us. We really enjoyed being here tonight. Thanks.
Thank you so much, Dr. Fucigna and Dr. Dolan. I will send out the slides to anyone who needs them. Thank you again.